Good afternoon or good morning to everyone, and welcome to today's webcast on improving patient experience, data analysis methods. My name is Dale Schaller, and I'll be moderating our session today, presented by the Agency for Healthcare Research and Quality's CAHPS User Network. Today's webcast is the second in a three-part series on strategies and methods for using CAHPS surveys to improve patient experience. Next slide, please. Our focus today is on the use of various data analysis methods to better understand patients' experiences, target improvement efforts, identify potential solutions, and track the impact of interventions over time. We'll start with a brief overview of AHRQ's CAHPS program, followed by a summary of what research has shown to be the foundational elements of patient experience improvement. And then we'll turn to two case studies. First, of how the Veterans Administration has used key driver analyses and journey mapping to focus improvement solutions, and then to how a large health system in Georgia has used a term called A3 lean methods, PDSA cycles, and root cause analysis to identify improvement opportunities in hospice care. We'll conclude with a few references to CAHPS resources for improvement, and try to leave as much time as possible to field your questions over the next hour. Next slide. Before we begin, I just want to review a few standard housekeeping details. If you're having difficulty hearing the audio from your computer speakers, you can always just change the audio selection so that WebEx calls you back and connects through your phone instead. If your computer freezes during the presentations, you can try logging out and logging back into the webcast in order to refresh the page. And if you need help at any time during the webcast, use the Q&A, the question and answer feature that I'm going to show you on the next slide. Next slide. So at any point today in the presentation, you can ask a question through this Q&A feature shown here on the lower right hand of your browser. Your WebEx screen might look a little different than what's shown on this slide, but in any case, look for this Q&A icon at the bottom, and then be sure that the drop-down option displays all panelists for you to ask your questions so that our team can see it. And we encourage you to share your name and or your organization when you type your questions so we know where you're coming from. Today's session is being recorded, and a replay of today's webcast and the slides will be made available at a future point on the CAHPS website. Next slide. So I'd now like to welcome and introduce our speakers for today's webcast. We'll begin with introductory comments from Karen Ginsberg, who directs the Agency for Healthcare Research and Quality's CAHPS program, as well as the Surveys on Patient Safety Culture, or SOPS program. Karen will be followed by two presenters from the Department of Veterans Affairs. First, Jennifer Purdy, who is Executive Director of the Veterans Patient Experience Program, and then Jim Schaefer, who is the Director of Surveys, Analytics, and Performance Integration and Deployment at the VA. Jennifer and Jim will be followed by Natalie McNeil, who is the Executive Director of Wellstar Community Hospice in Georgia. And again, I'm Dale Schaller. I'm a longtime member of the CAHPS Consortium, serving today as your moderator. And with that, I'm pleased to turn it over to Karen.
Hey, good morning, good afternoon, everyone. Thank you for attending today's program. As Dale mentioned, this is a second in our series of webcasts on quality improvement using CAHPS data. I'm going to start with a little bit of an overview about the Agency for Healthcare Research and Quality and the CAHPS program. Some of you might have heard this before if you've been on other webcasts. I just want to say that we continually have new users joining our webcasts, and I'd like to provide them with some background and context to the work you're going to hear today. So again, please bear with us if this is a repeat performance for you. And welcome to all. My first slide, please. So I want to tell you a little bit about the Agency for Healthcare Research and Quality. We're a research and development agency, Department of Health and Human Services, or a science-based agency. And so what we do is what's on this slide. We invest in research and evidence to make healthcare safer and improve quality. We create tools for healthcare professionals to use to improve care for their patients. And we generate measures and data that can be used by providers and policymakers and researchers and others to improve performance and evaluate the progress of the U.S. healthcare system. And it's a priority of my agency to push our science to implementation and to get our tools and products out to you, our users. Next slide, please. I'll tell you a little bit about the CAHPS program. So CAHPS, as you probably know, stands for Consumer Assessment of Healthcare Providers and Systems. And it's a program to advance the understanding and the measurement and improvement of patients' experiences with their healthcare. So we're now in our 26th year, and you might have heard of the CAHPS Consortium. This is the group that's responsible for the technical quality and oversight of the CAHPS program and products. And the CAHPS Consortium consists of staff from AHRQ, from our two funded cooperative agreements, the Yale University School of Public Health and the RAND Corporation, and our contractor, Westat. Next slide, please. So the CAHPS program has an active research agenda. It focuses on understanding patient experience, how to measure it, how to improve quality with CAHPS data, in addition to the work that we're really most known for, which is developing our surveys and item sets on patient experience of care. And we also conduct research on best methods to implement surveys. And while we haven't made this research, historically haven't made this research an end product in and of itself for our users, the work is becoming more critical to our stakeholders. And so we started an initiative here a couple of years ago in the CAHPS program to better explain the work that we've done in this area. And it is on our website if you're interested in finding it and reading more about that work. Next slide, please. So let me tell you a little bit about the CAHPS surveys. They are considered the gold standard for patient experience measurement. And let me just say a word about that. They measure patient experience, meaning what happened to a patient, did something happen or not, and how often did that thing happen. These are objective measurements of what happened to a patient as distinct from patient satisfaction, which we don't measure. Patient satisfaction refers to how patients felt about the care they received, and oftentimes that's based on what their expectations actually were for that care experience. So they measure experience, not satisfaction. The CAHPS program captures the patient's voice in the development of the surveys and the tools. The surveys measure patient experience of care in different settings. They are developed using standardized methodology and research findings and best practices in survey development. And all CAHPS surveys are trademarked, and that trademark is held by AHRQ. And what that trademark means is that the CAHPS Consortium has worked with the survey development process to ensure that the CAHPS design principles have all been met and the standards for testing. And that's the only way you can get a trademark, to use the CAHPS name. So I'm going to turn this back to Dale now, who's going to say a few words about the elements of patient experience improvement and what we've learned over time. Thank you all. Hope you enjoyed today's program.
Yeah, thank you, Karen. And before we get into our two presentations on data analysis methods for patient experience improvement, I just want to quickly set the stage by highlighting a fundamental conclusion that was reached by a team of CAHPS researchers almost 2 decades ago, based on an evaluation of a quality improvement collaborative with 8 medical groups in Minnesota that was convened over a period of about 18 months back in 2003 and 2004. The conclusion, and I'm just going to read this, it's on your screen, is that small measurable improvements in patient experience may be achieved over short projects. Sustaining more substantial change is likely to require organizational strategies, engaged leadership, cultural changes, regular measurement and performance feedback, and experience of interpreting and using survey data. So this fundamental observation that you can make small improvements in some aspects of patient experience, but that to sustain larger improvements over time, you really need to address organizational changes in leadership and culture, and the systematic measurement and feedback of data. This has been borne out over and over again over the last 20 years in the research literature, that has looked at case studies and expert reviews of high-performing healthcare organizations. Next slide. And so the research has consistently identified about a half dozen foundational elements or key factors that are crucial for a healthcare organization to achieve and sustain high levels of patient-centered care over time. And the first and most important is about leadership and governance, commitment at the CEO and board level to a strategic vision that embraces the importance of patient experience, followed by true partnerships with patients and families at multiple levels, including policy and planning, the co-design and co-production of improvement and redesign efforts, and of course at the individual level of care delivery between patients and their providers. The third factor is a strong focus on the workforce that embraces the importance of recruitment and training and the recognition and rewards for all employees, recognizing that positive patient experience is directly tied to positive experiences of the clinicians and staff who serve them. Next is the systematic measurement and feedback, which I've mentioned, using a combination of quantitative and qualitative methods to assess the experience and provide routine metrics for monitoring and improving performance. And finally, supported technology and infrastructure such as patient portables, telehealth services now more than ever, decision support tools, and a built environment that's not focused on amenities so much as structural elements such as wayfinding and noise reduction and access to light and natural elements that help to create a healing environment. And not all these elements are going to be covered by our speakers today, but we wanted to highlight them as context for the case studies that will be presented specifically on data analysis methods. And with that, I'm really pleased to be able to turn it over to both Jennifer Purdy and Jim Schaefer from the VA to talk about their experience with data analysis methods for improving patient experience. Jennifer?
All right, well, thanks everyone. I'm Jennifer Purdy, the Executive Director for Patient Experience at the VA, and Jim will introduce him. But we thought we would start first with how we have defined what patient experience actually is at the department. So if you wouldn't mind, go to the next slide. So in order to make change, to develop and engage our leaders and our staff and really start to improve the culture, we need to understand what patient experience actually is. So at the department level, we developed this VA definition. So it's the sum of all interactions that shape the organization's culture, that influence the veterans and their families' perception along their healthcare journey. Setting the tone for what experience is then helps us to begin to align our strategy and our initiatives to ultimately achieve excellence in experience. I'm going to turn it to Jim. He is going to talk to you a little bit about our data, and then I'm going to come back to you and talk to you about how we use the data into tools to actually engage and create change. So Jim?
Thank you, Jennifer, and welcome everyone to today's webcast. We hope that you find this information useful and maybe something that you could take back to your facility. Again, my name is Jim Schaefer. I am the Director of the Survey of Healthcare Experiences of Patients in VA, fondly known as the SHEP program. The SHEP program, we survey just about 1.8 million veterans a year. We have 4 core surveys and 1 that's in pilot, broken out into various patient care settings. The thing that we'll be going over today would be the inpatient or the HCAHPS protocol, the hospital CAHPS, where we use the HCAHPS survey and data collection protocol. So in primary care, we use the clinician and group survey with the patient-centered medical home item set. In specialty care, we use the clinician and group survey, and specialty care in VA for the SHEP program is defined as those top 9 specialty care clinics by volume. We've developed a CAHPS-like survey for care in the community. You can define that by patients receiving care through VA in the community via the Choice Act and now certainly the Admission Act. And given the onset of COVID last year and the diminishing face-to-face visits, we've deployed a telehealth survey, which is based on the CAHPS Clinician Group 4.0 visit survey. In the table here, you can see the monthly outgo and the response rates. And we fielded the telehealth survey in January, and data collection is set to close in the coming week. So we don't have a response rate on that just yet. Next slide, please. So with all of those surveys, what we like to provide to the facilities is the data, but specifically driver's analysis. So here, a driver's analysis is divided into, you can think of it as two different sets of questions, within the surveys. The outcomes could be defined for inpatient, the overall rating of the hospital. For primary care and specialty care would be the overall provider rating. And for community care, it's the overall satisfaction of care in the community. The drivers would be the remaining HCAHPS and CAHPS measures, respectively. And the driver's analysis here helps identify intervention or leverage points for improving patient experience, and it really informs the clinical and operational action planning. We try to focus on the process of a good clinical visit and how the patient experience interacts with that. So next slide, please. I love this slide. It's kind of busy, and it's an example of one driver's analysis. We have several, but this is just one. This particular slide is a structural map of a Bayesian network. I guess you could have a research assignment to investigate what a Bayesian network is. There's not really sufficient time to go into that this afternoon. So what we're looking at here is the Bayesian network, the structural map for recently discharged inpatients for VA overall. I should like to point out that these structural maps are provided for each facility at VA so that they can focus on those things that are important at their facility. Let's just describe a couple of the things that are going on here. The key performance indicator, right, that overall metric we're looking at is the overall hospital rating located on the left-hand side of the slide in that blue marble or that blue node. You can see that there's some orange nodes there too of various sizes, and here really size does matter. So the bigger the node, the bigger the marble, the more influence it has at improving that overall hospital rating. And you can see communication with nurses down at the bottom left-hand corner of the screen is the biggest node. So that does have the most influence on improving the overall hospital rating, followed by care transition, which is on the upper left-hand corner of the slide. And also, too, there's a bunch of arrows that are going, so it's kind of busy. So not only do these metrics have influence on that overall hospital rating, but they also influence each other. So if you take a look at communication with nurses, the bottom left-hand corner of that screen, that has a bidirectional impact with communication with doctors. So in other words, communication with nurses impacts communication with doctors. Communication with doctors conversely impacts communication with nurses. So wherever there are arrows on the each end of those lines would show you what metrics impact the overall hospital rating, but also how they influence some of the other metrics that are we're measuring here too. Also note that there are only 3 metrics that directly impact that overall hospital rating, and that would be communication with nurses, care transition, and cleanliness of the hospital environment. Notice that communication with doctors does not directly influence that overall hospital rating, but indirectly through communication with nurses. So here we've found that for most hospitals, that communication with nurses and care transition are the 2 biggest drivers of that overall hospital rating. All right, next slide, please. Here, we could find out potentially how much improvement could we see in the overall hospital rating if we focused our efforts on communication with nurses and care transition and some of these other metrics that are reported here. You can see that communication with nurses and care transitions are up at the top of the list. So if we were to improve communication with nurses by 10 points, right? So let's say communication with nurses went from 75 to 85 as reported on Hospital Compare HCAHPS. We could expect to see a corresponding improvement in the overall rating of a hospital of 4.6 points. Again, if we were to improve care transition by 10 points, so for instance, if care transition improves from 65 to a 75, we could see a corresponding improvement in that overall hospital rating of 4.1 points. So now that we've identified some leverage points and some key areas in which patient experience interacts with the process, we've identified maybe some potential areas for quality improvement initiatives. And at this point, I'd like to hand it back to Jennifer to let her describe what her and her program have done to build out patient experiences throughout VA. Jennifer?
Great. Well, thanks, Jim. So I'm going to try to go real quick here, and again, we'll be available for questions. Just to put it in perspective for you, the VA, we have 140 medical centers, over 1,600 clinics all across the country. We have almost 400,000 employees and take care of almost 9 million patients. So it's no small feat in order to really establish an improvement and a change in strategic direction, especially when it came to patient experience. So we went about it systematically. The first year that we really launched the experience improvement programs was really our year of building. So we defined, as we showed you at the beginning, what patient experience actually was. We also worked with subject matter experts and leaders inside of VHA to help us design the programs, name the programs, test the programs, and ultimately pilot tools that we were developing as solutions. And a lot of that was to gain trust, not only with our patients, but with our staff members. The second year was really all about deployment. So we really focused on engaging leadership, engaging employees, and developing what we call orchestrated touch points, visual indicators of experience that were happening. So you might feel it through the engagement and improved engagement with employees, but you also may see it with these orchestrated touch points, and I'll show you those in a minute. The third year really focused on coaching. Where should a facility start? Jim just gave you a great indication of how we use data to help align drivers and improvement. And I'm going to show you a few other listening modes that we had. But how do we assess it? And how do we understand where the facility is? With 140, we had some getting it right and some that had a ways to go to improve. Where were they on this maturity roadmap? How was their culture and what did it feel like inside the facilities? And ultimately, we started to see and measure outcomes. The fourth phase has been a year of rebuilding and continuing to deepen the maturity. So we began to focus on standardization across our enterprise. So everyone doing similar topics or similar tools so that we started to create a culture of similarity and consistency for our patients. We really focused on strengthening the skills of patient experience, change management, and communication, as well as adding on accountability for outcomes, adding it into performance plans and others. If you go to the next slide, please. I want to show you one of the other listening modalities. So we have a lot of data that helps us with the drivers of where to focus improvement. But we also utilized something called human-centered design. And what we did is we took what the moments that mattered most to our patients and their families. And what you're seeing here is an example of a journey map that was developed from interviewing patients across the country on their experience in an outpatient clinical encounter at the VA. We were able to look at their bright spots for before a visit, arriving to the facility, during the appointment, following or departing the facility, and then their aftercare. So we looked at bright spots, which you'll see indicated as like a little sun. And then the lightning bolt, you'll see these are some of the pain points. These are areas that veterans said, please fix this for us. And then from there, synthesizing all the information, we were able to identify the moments that mattered most to our patients when receiving outpatient care. And that's what you see along the bottom line. I got my appointment when I needed. It was easy for me to find my way locating myself to the appointment. I felt heard. And you can see how the others go. So not only the qualitative data, but a quantitative data really helped to set the stage for our improvement. And it also came with stories and pictures of veterans saying, you know, I'm confused about this, please help this, and you know, whatever it was. And I'll just give you one example. We had a patient we interviewed, and he said, while I'm waiting for my appointment, I'm watching everything you do. I'm watching if you're a team member. I'm watching if you are taking pride in cleaning up the facility. I'm taking care of veterans, my fellow veterans, before other employees, and telling those kinds of stories really help to get the attention and the engagement of the leadership and ultimately the staff. If you go to the next slide, what we did when we talked about culture change and orchestrated touch points at the VA is we developed, first and foremost, a training of customer experience that is standardized across our system. Every VA employee has on-the-moment training, which is customer experience principles, as well as a refresher, annual refresher. We introduced a lot of tools, but I'll just showcase a few for you. We Care Rounding was a tool that we used to engage leaders to really get them out and about, asking patient experience questions to both staff and to patients and doing real-time follow-up. We also wanted to set an orchestrated touch point of a standard phone greeting so that at any time, if somebody called a VA, they were given the employee's name, a warm greeting, and the location that they had reached. We improved the badges so that our name tag, basically, because at the VA we have a very small first name on our what we call a PIV card, which was the only way to identify, and veterans couldn't read it. They didn't even know who we were. So we developed something that would have a large first name so people knew who they were talking to, as well as their hometown, as a trick that we took from a hospitality industry to help to start to build connection. I talked to you about the on the moment, and then we also had one of the visual orchestrated touch points were red coat ambassadors. And at every VA, when you walk in, there are people in red coats, vests, or t-shirts, depending on the location of where they're at, but it's red. And they're there to welcome, to greet, and to help guide patients to their appointments. Hitting on that second moment that mattered most, it was easy to find my way to the appointment. If you go to the next slide, not only did we have a lot of foundational culture-changing tools that were strategically done first, we also began, as we began to mature and really assess where the organizations were and which facility needed what, we learned there were a lot of different programs that we needed to tailor to a facility. So this is just an example of all of the tools that exist. These are all on a knowledge management system that a patient experience officer in the facility could just simply click on it, and they get a whole toolkit about what is it, what's the value of it, how do they do it, how do they know it worked. And I'll just highlight one quickly is Commit to Sit. So this is an initiative that inpatient providers sit down with their patient when they round to give them more real-time a perception of time spent with them. And it's shown that if you sit or stand, if you sit, the same amount of time you sit as you stand, the patient, even if you do it for 1 minute, the patient, if you sit, the patient thinks you spent 40% more time with them. So tools and behavioral tricks like that were implemented. There is so much more we could share, but I'll just sum this up by saying we really used data, we used tools, and then ultimately technology to build the engagement. I'm going to turn it back to Jim now and tell you about how we did and what our outcomes were.
Thank you, Jennifer. And I'd like just to keeping an eye on the clock here, just take a few minutes to take a look at what happened after Jennifer went through had a focus on that leadership and employee engagement, building the patient experience culture at each of the facilities, went through the journey mapping and the development and deployment of these toolkits, particularly around communication. And by the way, that Commit to Sit toolkit is really empathetic listening and really, I think, has a tremendous impact on communication. So let's take a look at where VA was in 2018 compared to where they are now in 2020, and that's on the left-hand side of this graphic here, but also we'll take a look at 2020, compare VA to the HCAHPS community. So remember, this is publicly reported data on Hospital Compare. Well, it's now Care Compare. Over on the left-hand side of the graphic here in light blue is where VA was in 2018. And you can see that in 2020, we have a tremendously, we've improved tremendously where there's many more facilities. The percentage of VA facilities with reporting 4 or 5 stars with communication with nurses has tremendously increased. And in fact, we've also outperformed the community where we have a higher percentage of facilities that have 4 or 5 stars. Communication with nurses is important because that was one of the top driver in VA of that overall rating of the hospital. So next slide, please. Again, we could see the same thing. Next slide. Yeah, see the same kind of pattern here for care transition. We've had a dramatic shift to the right between 2018 and 2020, and the percentage of facilities reporting 4 or 5 stars in care transition. And again, for care transition, we are outperforming the community for HCAHPS hospitals. And the nice thing here too is we didn't have very many 1-star facilities in 2018, but in 2020 we didn't have any, so there were none. So we're continually marching to the right, or improving our scores because of I guess the interaction between the toolkits and the things that Jennifer and her teams have deployed at each of the facilities, and the understanding of the data that has occurred throughout VA over the course of time. Next slide, please, would be, so those were the 2 key drivers of the overall rating of the hospital, right? The care transition and the communication with nurses. And again, here we see the same pattern with the overall rating of the hospital, where VA has many more, the higher percentage of 4 and 5-star facilities in 2020 than we did in 2018. And again, compared to the community, VA does have more 4 and 5-star facilities. So through the understanding of some of the data and through some of the focus on that patient experience culture at each of the facilities in VA, I might add, we've really, I think, improved the patient experience in VA. I'm really proud of what we've done here, Department of Veterans Affairs. Anyway, I'll turn this back over to Jennifer, and she could take us home. Thank you, Jennifer.
Just quickly, I'll say that I think some of our lessons learned, and it's just wonderful that with Dale's introduction, leadership and employee engagement is absolutely key. It was the foundation of all the improvement. Understanding what was important to patients, utilizing human-centered design in the moments that matter really helped to bring home the personal connection of the why we want to make the improvement. We really looked to data, and Jim and my team really focused hard on where were the biggest bang for the buck, where were those big marbles, as he said, and how did we help develop improvement projects to target those. And then finally, I'll just say celebrate this success. It took us 5 years, and you can see the amazing outcomes that have happened. And I'll say it's the nearly 400,000 people that are working out there every day that made this happen. And we're just proud to be able to share VA's story with you. So thank you very much for the opportunity. Dale, I'll turn it back to you.
Great. So thank you so much, Jennifer and Jim. Before we hop into the next presentation by Natalie, I just want to say that was a marvelous way of sort of linking the data analysis focus that Jim presented with the overall organizational changes that you described, Jennifer. And I do think it sort of is representative of both the large organizational culture, leadership requirements for advancing patient experience and the individual sort of tools and analysis methods that underlie both the sort of the quantitative and qualitative ways of monitoring and sort of tracking improvements over time. So very well done. Thanks so much. I want to remind everybody to continue to send in your questions, and hopefully, Natalie, turning it over to you, we'll still have time at the end to ask a few of those. So Natalie, take it away.
Great, thank you. So I'm Natalie McNeil. I'm the Executive Director of Wellstar Community Hospice, and today I'm going to share our CAHPS improvement project that we had in our organization related to a single metric. And this will probably equate more to a department within a system, whereas Jim and Jennifer just did an excellent job of giving you a really big picture through an organization. Mine's going to be more focused on a much smaller group of people. Next slide, please. So my team is part of Wellstar Health System. We're in Metro Atlanta. My hospice serves 7 counties, 6 hospitals, 2 freestanding inpatient hospice units, and we have about 2,500 admissions per year. And for a hospice agency, that's actually considered to be a pretty big hospice agency or hospice office because we are very limited in our licensure and how big of a service territory we can have. Next slide, please. Wellstar has recognized that death is part of the healthcare experience, and they have committed resources to hospice care since 1981, and that's actually before hospice became a Medicare benefit. So they're very invested in this line of service for our patients. This commitment to exceptional care and quality for patient experience has allowed my team a place in the continuum of care for our patient population and has given us access to resources and experts related to patient experience improvement, lean methodologies that we would not have had otherwise, being such a small organization, unless we really tried to go out and figure this out on our own. Next slide, please. While many hospices do utilize the PDSA Plan, Do, Study Act, it's often less structured than a formal lean process, and the intricacies of the lean process can be very overwhelming at first. It did overwhelm our team, but as we became more and more familiar with the structure, this became a non-issue. Our leaders did receive training and coaching on how to emphasize a culture where problems are not viewed as burdens, and the focus remains on the process and not the mistakes. And we were very effective in this area because our staff now stands up and says, I'm the person that was involved in this particular situation, and this is how I feel like the process was broken. And so it really shifts that. Next slide, please. So after our annual Quality Assurance and Performance Improvement CAHPS review, our team felt that we should shift our focus from the overall hospice rating and look at a specific area. And a big piece of that was because our rating for overall was already so high, we felt like there was very little that we could do to improve that. We had been in the upper 90s for a while, and while we wanted to maintain that, we felt like we could really hyper-focus on some other areas that did not have the scores that we were expecting. Our team did choose listen carefully regarding care problems, and we felt like this was measurable and movable based on changes that we could make internally. We feel like listening is really a hospice core value. We have to listen to our patient to understand how they want their death experience to be for both them and their family. And being heard significantly impacts their overall experience. So with a starting point of 68.6 and the number of surveys that are returned historically, we did work with an analyst who helped us set our threshold, target, and maximum goals. And those were very methodically thought out and determined as to what those should be, with our end goal for the year being 88.5, but threshold and target being midpoints throughout the year. Next slide, please. So we utilized the A3 methodology, which refers to the size of the paper that we communicate with our staff on when we print this off for them to see. And it puts everything onto one page, and we'll go into more depth in this. We'll break it down a little bit further. I know it's really hard to read, very small right now, but I wanted you guys to see how it lays out on the page so that the team can see how we're performing both visually and through our to-do list on here. So next slide, please. We utilized for our root cause analysis the 5 whys approach, and the numbers on the last page were actually real numbers, but the 5 that I have on here is just an example. So we went through the 5 whys again, as I said, for the root cause, and we did a fishbone analysis for our contributing factors. And to walk through this, so the questions that we asked: why were the listening carefully scores low on the CAHPS survey? And when we were looking at the numbers, we saw a very low number returning surveys had been completing that particular question. So that made us dig a little bit further. Why did only 5 people get the CAHPS survey? Well, more people did get the survey, but this was just a follow-up question to them actually having a problem. So we're glad that that number was low, because it meant that we didn't have a lot of people that had problems during their care, but it has a huge impact when you have that low of a number on your overall score. We wanted to know why they felt like we didn't listen to them. That was because their problems weren't resolved in a way they felt like they were heard. We wanted to know why we didn't address their need or why we didn't hear them. That's because we weren't verifying that we understood what they were trying to communicate with us. And the last question that we asked is, why did we not verify that? And that's where we found that our process was not defined and that we did not have any responsibility delegated. And therefore, it wasn't a human failure from someone not doing what they were supposed to do or understanding their role. It was that we did not have that assigned to anyone. Next slide, please. This is a general fishbone analysis. I'm going to show you guys on the next slide what our real fishbone looks like. But the great thing about this is it acts as our brainstorming session to identify all of the factors that could be contributing to the low scores, also known as an apparent cause analysis. If you want to go to the next slide, you'll see our actual fishbone. And you know, some of the things that we found when we were really talking this through as a team is that our staff were using medical terms that our patients and families didn't really understand, like words like actively dying. You know, when we talk to people, we always hear people say, well, we're all dying, aren't we? And that's not really the case. We are actively living. And to define a process of actively dying, when someone has a chronic illness, we know that there are phases that they often go through, and that's how we know when someone's approaching death, and we have to communicate it in a way that a family can understand that. We also realized that our families were in distress, and they don't always retain the information that we're giving them, and we had to really look at, was our communication that we were leaving behind in education for training effective, and we made a lot of changes around that. And then we also found out that we were communicating with the wrong people. The caregiver in the home might not be the person who is the person that's actually making the decisions, and making sure that we had that documented in the chart so that our team could follow up with them were some of the things that we came up so that they would know that we were truly listening and communicating with the right people. Next slide, please. So in hospice, we have some unique challenges. The person that is completing the survey is not the person that actually received hospice care. Our surveys are sent to patient families 60 to 90 days after the death of the patient. And we have to help the family realize that the care that we're giving is to the patient, and we need to be judged based on the patient's experience, not always their experience of our care, even though that does play into it. So a great example of this, we see in some of our cultures that we serve, people believe that in order to go on to the next phase after death, that they have to experience extreme pain so that they can shed all of their earthly sins. And sometimes while the family may believe that, the patient may not. And so in talking to the patient, our patient wanted pain control. They did not want to experience pain. They didn't feel like that was a key for them to go on to the next phase of their life spectrum. So you can see how a family may grade us very differently than the patient may have, and helping them communicate that's a big piece for us in hospice. As we talked about earlier, the listen carefully to care problems is not always evaluated by all survey recipients. You do have to answer yes to another question in order for that one to be counted. We know in hospice too, again, because this is a family filling out the survey for us, that bereavement first can really impact their emotional fluctuations. And we do offer bereavement services. We follow our families for 13 months afterwards. But we know that, birthdays fall different places, whether it's the patient's first birthday or the family's first birthday, anniversaries, holidays. Emotions really do impact scores. And then the number of days on service is another huge impact to our scores. If we aren't even surveyed on patients who are on service for 2 days or less. They have to be on a certain number of days before they actually receive a survey. And the more time that we have to build trust as death approaches, we find in hospice that our services are rated higher. It's not based on a single encounter. Our survey is based on their entire hospice experience. So it can be really hard to drill down to a specific incident, especially when these data points are coming in 3 months later. Next slide, please. So outcomes and data evaluation, we have made sure to really communicate the peaks and valleys to our team. These are our actual results that we had, and you can see on here that we've had several things happen. The lavender line, the lighter purple line, is the goal that we had set, and the first thing that we encountered was some leadership changes that really impacted our follow-up efforts and our complaint resolution process. You can see further down the line, we knew that the scores coming in 3 months after the holidays might be impacted. We had prepared our team for that, and they were significantly impacted. Then the next month, huge increase for the next 2 months, and that's because we had a significant amount of training. We used simulated environments for our team so that they could really learn how to communicate. We brought in volunteers and mannequins and all kinds of ways for them to practice, and you can really see the payoff 3 months later that we were using that in our actual work with our patients and families. And then the last dip that we had was a medical record update and had to do with some of our communication timeliness and alterations to visit processes and things like that. So, we knew that that was, again, 3 months after that had happened. So big fluctuations our team really needed to understand that. And this was actually a specific piece that was on the A3. You might recognize the bar graph there. And then on the next slide, we have our grid. This was also part of the A3. This was on the other side of that A3. And this is a really nice grid that the staff can follow. They can look at what the problem or issue was, what the actions and solutions we're taking are, so that they can all be on the same page. We assign owners so that there's a definite person to own that process and see it through. And then we had the due dates on here so that our team knew what we were working toward. It's all about communication and making sure that everybody's on the same page, and we felt like that was a great way to do that. Next slide. So our key principles for success, we did have great success. We actually came in at over 90%. If you recall, our goal was 88.5. So we made the changes that we needed to make, and we did move those targets. Our team was really proud, but there were some things that we took away We had a lean expert that we borrowed from the system for this project to get us started and help really educate us on how to do this. The more we practiced, the better everybody got at it and really bought into the process. We made sure to keep that focus on process improvement off of people failure. We had checks and balances. We made sure that we were looking at all of the problems in the same methodical way, and again, really tried to focus on what part of our process didn't work. And we also tried to focus on the parts of our process that did, so that we made sure to keep those in our overall performance. And then we, with the help of that fishbone, we recognized our causal factors in addition to the root cause, so we knew what else could be impacting that. And then we set really attainable goals so that our team could feel the movement and the success that we had. And then next slide. This was what our team came to the conclusion of at the end, and I'm just going to read it directly from here. It says, to enhance the patient experience, we must focus on each person we serve as an individual. What seems like a simple measure, such as listening, has a multitude of factors for each respondent that will impact their score. Without understanding each person we serve, we'll not be able to sustain improvement and provide the best end-of-life experience possible for our patients and their loved ones. Next slide. Again, I'm Natalie McNeil. If you have questions outside of here, please feel free to contact me, and I'll be happy to share that if we don't get to it in the questions today. Thank you. Back to you, Dale.
Yeah, thank you, Natalie. Great presentation, and I do think we're going to run short on time for fielding all the questions that have actually come in. So I think knowing that the slides do have contact information for both Jennifer and Jim from the VA and Natalie, I think, you know, those of you who aren't not going to get your questions answered today can directly follow up. So with that, let me just remind you that to ask a question, you can send it through the Q&A icon that you see in the lower right-hand corner of your browser. I'm going to start with a few questions that have accumulated here for the VA. And Jim, I'm just going to send you a question. There's a couple of questions from Albert Farias related to analyzing the data by race and ethnicity, whether you have taken that cut at any of the data that you've looked at, and if so, have you noticed any differences in the actual improvement within different race and ethnic groups within the VA?
Oh, hey, Dale, that's a great question. No, we really just more or less stratified the data by race, ethnicity, and gender, and really haven't seen if there was any improvement by those categories. But that's actually on our docket to do this year to see if there's been any improvements. And of course, it's difficult to examine the improvement by gender in VA because the population of women in VA is just so small. So at the facility level, it's very difficult to make that determination, by improvement, reliably make that determination for improvements. But that's on our agenda for this year.
Okay, great. And just another sort of data-related question for you, Jim. The star rating comparisons that you made, did you have any ability to do analyses to know whether the improvements that you're actually seeing over time and by individual hospitals are due to CAHPS improvements specifically? I mean, the sort of interventions that you did, and not by other sort of confounding factors such as, changing demographics or changing in funding or other sort of external factors?
No. So I think the question is whether, let's say, the deployment of the Commit to Sit toolkit improved communication in facility access. No, we really didn't do that. And you could see from Jennifer's portion of the presentation that her and her team really had a really broad approach to improving the patient experience from engaging leadership and employees, and so not necessarily at the facility level for individual toolkits. And in my opinion, I don't think that using any of the CAHPS surveys would really give you a marker for success on those individual quality improvement initiatives. That really needs to be measured locally. So I can't measure improvements in Walla Walla, Washington, from where I am in Durham, North Carolina. That's something that really does need to be done locally.
Right. So to you, Jennifer, a question related to the actual improvement work. What kind of strategies, this is from Kevin Phipps, do you employ to keep local level leaders engaged with your patient experience outcome measures? I mean, so for example, he suggests maybe using visual management practices. How do you keep the local VA staff engaged in all this work?
I would say there's multiple venues to do that. Definitely data and visual management boards are used. I would say there's many ways to do that. Some of the things that have been the most successful for us are the promotion of best practices. So we developed a patient experience annual award ceremony where the most improved agency gets a secretary level award. It's a really big deal. We highlight local innovations and have and call for innovations in patient experience that's voted on across the country. Again, another very high level award is done. So we look at recognition. Then we also really work with the leaders that we look at improvement. I'm sitting in front of them every quarter from the senior doctor at the VA all the way down through all of the leadership chains. We do a lot of community of practice calls, a lot of change management calls, showcasing shared best lessons learned, best practice. So I would say data, that power of recognition, community of practice, and then in addition to that, we kind of brought it mainstream because we added it to performance plans. You had to assess, you had to build action plans, you had to show improvement on your action plans. So many different ways to do that.
Thank you. So I'm going to tee up one question for you, Natalie, before I think we're going to have to close out for the afternoon. You described a lot of very detailed analysis steps that you took, like the fishbone analysis and the A3 lean. What kind of effort does it take to actually do all of that? And what are the biggest challenges that you face when you do the various analytic steps that you described?
Sure. So for us, getting our team together is pretty hard because our team is in the community serving patients in their homes. So we don't see a lot of each other in the office together. So finding a time to get an interdisciplinary team together that had various people from throughout, not just management, doing this together really helped us drill down, but was difficult to get everyone together. We dedicated probably, I would say, an hour to 2 hours every other week in the beginning, and then had some specific subgroups out of that who worked together, like on our education that we were leaving behind in the families' homes. We had a team of people develop that, so that was done outside of the general meeting. So all in all, probably about 4 to 5 hours a month in meetings for various staff members.
Okay, thank you. I'm going to actually, unfortunately, have to move us toward closing because of time. I want to just briefly mention that a number of the questions that were fielded today for the VA and also for Natalie with the hospice example are actually addressed in the CAHPS Improvement Guide, which is one of the resources that we maintain on the AHRQ CAHPS site. The issue of do driver analyses get reflected and how do you do that is included in this guide, along with specific interventions that are actually mapped to the major domains of the CAHPS health plan and clinician and group surveys. I mentioned at the outset, and Karen did too, that this is the second in 3 webcasts devoted to patient experience improvement. We're going to be presenting another webcast on March 24th, again from 2 to 3 in the afternoon Eastern time. We'll be featuring 2 case studies then of improvement in large organizations, this time with UCLA Health and Kaiser Permanente. You won't want to miss that, so stay tuned. And the way to keep track of what's going on with CAHPS and to be able to register for these, as you know, since we have well over 500 participants in today's webcast, next slide, is to sign up for email updates. You can do that by going to the AHRQ website and click on the right-hand corner, and you can choose all of the email updates that are associated with CAHPS. So with that, I am going to basically ask you to send any questions or comments that remained to our email address at CAHPS1@westat.com. Our 1-800 number is 1-800-492-9261. And of course, the CAHPS website, which is www.ahrq.gov/CAHPS. So with that, I want to thank you all again, particularly our presenters, Karen, Jim, Jennifer, and Natalie. Thank you so much for the excellent information. Again, the slides for today's webcast will be posted at a future time. You can check back on the CAHPS site for that information, as well as an archived recording of today's session. We invite you to visit the AHRQ site at any time, contact us at any time. Thank you again for joining us today. And this concludes our webcast, and we look forward to having you back again later in March. Thanks, and have a wonderful day.